Hello everyone, I'm Alessandro Fugazza, a gastroenterologist at the Digestive Endoscopy Unit at Humanitas Research Hospital in Milan.
Hi, I'm Andrea Anderloni. I'm the director of the Pancreatic Endoscopy Unit at Humanitas Research Hospital in Milan.
First of all, on behalf of all my co-authors, I would like to thank Gastrointestinal Endoscopy for the opportunity to discuss about our paper entitled International Multicenter Comprehensive Analysis of Adverse Events Associated with Lumen-Apposing Metal Stent Placement for Pancreatic Fluid Collection Drainage. Andrea, can you explain a little bit about pancreatic fluid collection drainage?
Yes, of course. As you know, pancreatic and peripancreatic fluid collection drainage has changed a lot in the last decades, moving from a more invasive and aggressive treatment, such as surgery, to a mini-invasive approach with endoscopic drainage. This kind of approach has been shown to give a better outcome to our patients in comparison with surgery. Moreover, in the recent years, the availability of the new lumen-apposing metal stents allow us to treat this patient in an easier way that becomes safer and even more effective. So, taking in account all this data, Alessandro, I would like to ask you, as a lead author of this interesting paper, what was the main idea that drove you to run such an interesting paper on this topic?
Thanks, Andrea, for the question. So, data on adverse event with lumen-apposing metal stent placement in this setting of patient are heterogeneous, and only few studies are published in literature. In order to better understand the real rate of adverse event, to avoid them and to maximize the benefit from the use of lumen-apposing metal stent, we conducted a multicenter international retrospective study from 15 centers, 11 in Europe and 4 in USA, of all patients treated in this institution with lumen-apposing metal stent for the management of pancreatic pseudocysts or wall-of necrosis between March 2013 and October 2017. The aim of this study was to evaluate the incidence, severity, management, and risk factor of adverse event related to the use of LAMPs in a large cohort of patients. Moreover, we performed a nested case control analysis in patients with or without adverse event, looking for factors associated with occurrence of adverse event. During the study period, a total of 333 procedures in 328 patients were performed. 5 patients have been treated with 2 LAMPs in different sessions. Technical success was 97.9%, and technical failure occurred in 7 patients that have been treated with new LAMPs or plastic stent placement. After exclusion of patients with technical failure, loss to follow-up information, and deaths are related to LAMPs, the rate of clinical success was 89.5%. Finally, 79 adverse events occurred in 74 patients, consisting of 24.3% of patients from our study population.
So, Alessandro, that seems a very robust data on this topic, but let me ask you if you had the opportunity of going deeper in this data, analyzing and stratifying the results in terms of the type of the complications, the severity of them, and maybe also the timing of the complication itself.
Thanks, Andrea, for this suggestion. Basically, the most common adverse events were bleeding, stent migration, infection, and stent occlusion. Even more important, according to ASGE lexicon, the majority of adverse events were mild or moderate, with only 6.3% of severe adverse events. Regarding the timing of adverse event, early adverse event within 14 days from LAMPs placement were observed in 43% of cases. in most of the cases were bleeding and infection. At the same time, stent migration was significantly associated with longer time from stent insertion as compared with other events. The adverse events were managed in the majority of cases with endoscopic or radiologic procedure or in a conservative way, and no adverse event required surgical intervention. On univariate analysis, many factors have been considered. Case and control group did not differ statistically in terms of age, gender, indication for drainage, etiology of pancreatitis, fluid location and diameter, stent type. There were, however, some difference. Compared with control, cases were more likely to have performed drainage of walled-off necrosis versus pancreatic pseudocyst and to have concomitant percutaneous drainage, while they were less likely to have PFC extending into the paracolic gutter to undergo nasocystic tube placement and pneumatic tract dilation. However, on multivariate analysis, only the drainage of walled-off necrosis and pneumatic tract dilation remained statistically significant.
Well, Alessandro, after presenting all this data, can you tell us which should be the take-home message for the gastrointestinal endoscopy readers and for the lumen-apposing metal stents users?
Yes, so LAMS has been shown highly effective for the management of pancreatic fluid collection drainage, as you already said. However, adverse events can arise up to 24.3%, as shown in our code. Drainage of one compared with pancreatic pseudocyst is associated with an increased risk of adverse event. Balloon dilation seems to reduce the risk of adverse event. Therefore, the rate of adverse event is not negligible and should be carefully considered before using this stent for drainage of pancreatic fluid collection. For the prospective study, aim to maximize clinical success and to minimize the risk of adverse event for patients with pancreatic fluid collection are needed.
Finally, Alessandro, before finishing this nice interview, I want to ask you a very last question. After publishing this interesting paper with such a robust data, did you change anything in your daily practice when using the lumen-apposing metal stent?
Yes, because we consider the bleeding not only a late adverse event, but also a possible early adverse event. And also we start to dilate every LAMS placed for one drainage.
So thank you, Alessandro. Thank you for your time and for sharing your data with us. But more important, thank you for the effort to put all this data together and to produce such a nice paper. Thank you to all of you for listening to this interview.
Thank you. Bye.